This is the second workshop in a series of workshops from the First Aid Club. This is the First Aid Responder, and we are going to build on the knowledge we took in the Prepared Civilian workshop, which is a two-part video. And we are going to go deeper. There is a lot of information in this workshop, and we are slowly going to migrate towards the medical part. So what will we see over here? We're going to look at communicating with our patient in a holistic way to see what's going on, what they're feeling, and so on. We are going to cover the patient assessment and the Glasgow Coma Scale, which is a metric that we use to evaluate how badly injured the patient is, and the vital signs. Communication. Communication is very important because it is the first interaction with your patient to find out what's going on. And one of the advantages of this is we are able to determine their mental status. If they are able to put words together, if they are able to speak clearly, and whether or not they are under the influence of alcohol or other opioids or other substances. The questions we ask are structured around the mechanism of injury. Mechanism of injury means that it will lead to a mechanical break in the skin, the bone, and cause bleeding. The nature of illness would be an environmental factor that provoked an underlying medical disorder, like asthma, for example. So, for the mechanism of injury, the first question we will ask is what happened? Because I want to make sure that the mechanism of injury that injured my patient will not injure me. Additional personnel involved? Is the patient the only one that is hurt, or are there more than two people hurt and some of them went to seek help? Or did someone hurt my patient? I need to know. Are they under the influence of anything? For the nature of illness, what symptoms are they exhibiting? What are they experiencing? Tightness of breath, pain, what's going on? Do they have any allergies that I need to be aware of or that may have caused a mechanism of injury? Are they taking any medication? There are some classes of medication that should start ringing bells in my head if I hear about them. Anything that is related to heart, to the heart rhythm, we would call a beta blocker. This is used to treat abnormal heart rhythms. We have an alpha blocker, which is used to treat high blood pressure. I want to see if if they have any allergies. They're taking any medicine for allergies, which would be antihistamines. So on and so forth. I want to know their past history. Has this happened to them? And if it has happened to them, how did they respond to it? What did they do that helped them? And if it hasn't happened in the past, that's a different story. I need to try and help them. When was their last oral intake? Meaning the medicine they are supposed to take, if they are taking any medicine, did they take them according to the prescription? Did they take more than they should? And have they eaten anything all day? Some patients may not need medicine, they might not be taking any medicine, but the issue would be that they didn't eat all day, and they would be busy. So it doesn't work that way. You are dehydrating yourself. And what are the events that led up to the present time? Because all of this is like a story of their day, will put what happened into more context. So now if we take a look at these, this one, third, this creates the mnemonic sample. I can remember this and I can ask questions according to that. Let's take a look at the primary assessment. It's very useful because even before I have my first interaction with my patient, I can get a general impression of what's going on with them. It's called eyeballing. Do they look tired? Is there any injury that is objectively visible? Are they limping? Do they look injured or not? Then I'm going to follow the mnemonic ABCDE. It might be counterintuitive because in the first workshop we said that it would be CAB, but this is just for the case of what I need to remember. The priorities might be different. So let's take a look at what's going on here. A is for airway and C spine because when we consider any patient with a head injury, first we have to do is the spinal immobilization, which we call MIAS or MILS, which naturally comes with some sort of airway management. B for breathing, chest rise and fall. Bleeding, which is part of circulation. Disability, cerebral function and the level of consciousness. Are they passing out right in front of me? Are they trying to stay awake? What's going on? E, exposure, finding all and any injuries. This is where I have to start removing clothing. So these are the ones that I have to remember, but I might come up with a patient where I first need to expose the injury to stop the bleeding and their airway is okay, but they may not be breathing. There are many different priorities and they play around. Let's take a look at the airway and C-spine in more uh, detail. We need to rapidly evaluate for patency. So how do we do this? If they are talking, if they are talking and I can understand what they're saying, their airway is most probably patent. It is open. If they are not talking, if they are wheezing, if something is going on, there might be an obstruction. If they are aspirating any fluid, doesn't mean talking. It's not equal to talking, so I need to get the suction. If it is compromised, we need to do the head tilt, chin lift, or the jaw thrust to see if there is any oral airway obstruction directly visible from the mouth that I can use the finger sweep to remove. If need be, we can advance to a mechanical means. This involves the nasopharyngeal airway, which is basically a tube that we put in the nose, and it will clear an area. It will open the airway from the top, but it does not secure it. We are going to look at the difference between opening and versus securing. There's a difference. Oropharyngeal airway, it is a plastic device that we put inside the mouth to open an airway passage. The supraglottic airway, we will take a look at that later because now we are going semi-invasive. Endotracheal intubation is invasive. Transtracheal tube is invasive, and we have something called the cricothyroidotomy, which is a surgical airway. We'll take a look at that later on. What we're going to cover now are these. These are the least invasive. So let's take it the nasopharyngeal and the oropharyngeal airways. The nasopharyngeal airway is basically a tube with a certain length and diameter, opening diameter. We will talk about how we measure them to see that it is appropriate for our patient, not too short, not too long, not too big, not too small. So let's see what's going on here. Let's first see that we pick the right size. Those numbers 22, we have here 22, 24, 26, etc. These are the sizes. 28 French, and this is the common one. It's not too big and it's not too small. How do we measure it? I'm going to measure from the nose to the earlobe, to the bottom of the ear. And this tube should not be stretched out. If it fits in between that gap, in between this gap, normally, then the tube is the right one. I will make a pig snout or a snout with the nose, and I put it parallel to the palate, to the nasal palate. It should be put parallel like this. I don't put it up like this. It has to be perpendicular. So this physician is only finding the position, then they're gonna put it in straight. Let's take a look at the contradictions. It will not regain consciousness or expect it to. We will use the nasopharyngeal airway if my patient is temporarily unconscious, but they will wake up again. We saw this in the revolution when the riot police were using tear gas. People were losing consciousness, but once they were in an area with open air, they regain consciousness. But as medics, what we do is we put the nasopharyngeal airway and it will not get dislodged. They will be able to wake up, okay, and then they can pull it out later. Tube size too small. If it's too small, you will not have sufficient airflow. And if it's inserted upward like this, it will never touch here. This is where it needs to go, the pharynx, because it's a nasal through the nose, pharyngeal, because of the pharynx. Let's take a look at the oropharyngeal airway. This is how it looks like. I measure it in a similar way, but notice how we flip it over like this, because this is how I want to start. This is how it's going to end up between the bottom of the ear or in line with the jaw and the mouth. So this is how it ends up. The air will move in like this and down here. Normally in CPR, when we do not have time to intubate, when we are in the emergency field and emergency services, we don't really intubate. We put the head tilt chin lift, the head is tilted backwards and the chin is lifted upwards. That means that my airway is patent, and I put a pathway because of the tongue. That's the oropharyngeal airway, and it's hitting the pharynx. Insertion. We start with the tip facing the roof of the mouth. So over here, the tip would be like this. We start off like this. That's the tip. Tip facing the roof of the mouth. It's not supposed to be tongue, it's supposed to be mouth. Okay. 190-degree turn to turn it over. 180 degrees. So it's going to go like that, then it's going to twist over as we push it in and twist it over so that it turns into this way. Contradiction, gag reflex, they might vomit if they are conscious. Semi-comatose, they have to be completely out, and it secures the airway. Does not secure the airway. These are contradictions. If my patient has a gag reflex, I need to avoid it. If they're going to wake up, I need to avoid it. If it secures and it does not secure the airway. If I need to secure the airway, I will not use this method. C-spine, every trauma patient, unless conclusively cleared by a trauma physician, breathing and ventilation. If the patient is breathing, I need to move on to the next priority. If they are not, means apneic, I need to start the ventilation with the back valve mask with supplemental oxygen. I need to ensure that the airway remains open, and I need to start preparing for a mechanical airway. If they are breathing, we need to assess their rate and their SpO2 levels. We will talk that in in the vital signs. I need to observe the chest rise and fall and keep talking to them. And to a degree, an extra one that we will see later is using the stethoscope. Bleeding. Perfusion is adequate blood supply to the tissues, and we can test this via capillary refill. One way to do it is I can take the base of the nail and I can press on the nail and see how fast it refills. That's how I can see the capillary refill. Pulse evaluated for its quality and regularity. If it's weak, strong, regularity, regular, irregular, thready means fast. Capillary bleeding, scratches, open tiny capillaries just below the skin surface. Venous bleeding deeper inside the tissue and can be controlled with direct pressure, not necessarily life-threatening unless the injury is severe and the bleeding cannot and the bleeding isn't controlled. Arterial, lacerated arteries spurting bright red blood has to be controlled fast, even if it's small. There can be significant blood loss. Disability, cerebral oxygenation, how well the oxygen is reaching my brain. Cerebral hypoxia is when, for example, when I stop breathing and I hold my breath. It's related to carbon dioxide going up. Reduction in the atmospheres and the oxygen's partial pressure in the atmosphere when I'm at high altitudes. Examples of the high altitude would be mountain climbing or in the aircraft. Hyper and hypocapnia, which is the CO2 levels. My CO2 levels cannot be too low and they cannot be too high. There is a certain percentage for the CO2 levels. We use a capnometer. Hyperbaric oxygen therapy for aerospace medicine and altitude sickness. This is a tube basically that they put you in and they flush oxygen, a high partial pressure of oxygen all around you so that it can highly perfuse the cells with oxygen. If you take a look at something, you can look it up. It's called ECMO. Extra corporal membrane oxygenation. They mainly use it for babies who are not being able to ventilate properly and their lungs have not fully developed and they're premature. They would use ECMO. These are one of the uses. Exposure. Expose and evaluate the wounds. Depth, the mechanism of injury, severity. How big is it? Find and control the bleeding. Pressure, later on tourniquet. We're going to see it in more detail. Skin appearance. Cold and clammy means there's something wrong with the perfusion. Warm, bruises, yellow, jaundice. This means jaundice. The glass glaucoma scale. The glass glaucoma scale, like we said, it is a metric to evaluate how well or not, how badly my patient is injured. The domain or activity, what were they doing? Um, not what they were doing. I'm gonna look at certain things that the patient can provide for me based on certain triggers, and I'm gonna give it a score. Let's take a look at what we're looking at. The domain or activity is the eye opening, the best verbal response, and their best motor response. So, if they open their eyes spontaneously, I will give them a 4. If they only open to speech, I give them a 3. If I have to induce pain for them to open their eyes, 2, and none will be 1. Best verbal response. Are they oriented? Can they answer my questions? What day is it? What happened? Who was with you? What's your name? Do you have any family members? What are you doing here? If they can answer me properly, it's a 5 out of 5. Are they confused? Are they telling me stuff that's inappropriate? So if I ask them what day is it today, they tell me I had such a great lunch today. It was amazing. It was so good. You should try out the restaurant. They are confused. They are. It's an inappropriate answer. Incomprehensive is when they start slurring. It's like all the words are going together, and if they don't give me any verbal response, it's a 1 out of 5. Best motor response. They're obeying what I'm telling them to do. That's a 6. If they are localizing, it's like they are able to tell that I'm pressing on their hand. Withdrawal, if they take it back to because it's painful. Flexing, extending, and none. So the final score is eye opening plus the BVR, which is the best verbal response, plus the best motor response. So if I have someone who was a victim of an accident, their eye opening equals to 3, their BVR is equal to 2, and their best motor response is, say, equal to 4. We add them all together, 9 out of 15. They need a hospital. So, coma is 3 or it's death. 15 is fully alert and oriented. This is the score that I got from this little example. So they need to be seen by a physician because it is quite low. The vital signs. Now the fun part starts. In the vital signs, I have the heart rate, which is measured in beats per minute. The blood pressure in millimeters mercury. Respirations, breaths per minute. Temperature in degrees Celsius. Oxygen saturation. In percent. Glucometer. Glucometry. Blood glucose levels, which is the blood sugar. In milligram per deciliter or millimole per deciliter. Depends on the device and the settings. Important. Stay calm to keep your patient calm. Listen attentively and rest assure them. Make sure they answer your question, not someone else. You can discreetly palpate. Palpate is feel. Feel the radial pulse, which is over here, as you talk to your patient, and you can get a general impression of what's going on with their heart. Now, the blood pressure. Blood pressure is very important because it tells us the overall pressure when the heart is pumping and when the heart is relaxed. We use a fancy meter called a sphygmomanometer. That's the sphygmomanometer. It is a mouthful to say, but we can break it down. Sphygmomanometer. Sphygmomanometer. Sphygmomanometer has several parts in it. Let us get to know each other now. We have the meter, millimeters of mercury. We have, this goes to the BP cuff that we put around our arm. Screw valve. We have the bulb. The rubber bulb. Over here, we have a uniform ball valve. So when I compress this, when I compress the bulb, that ball valve will block this air from getting out and the air will go from here. When I want to reinflate it, the ball valve goes back inside. It will be disengaged and it will let the bulb fill up again. This piece of metal is so that I have more dexterity. What do we get from the blood pressure? The systolic, systemic circulation, and diastolic, heart is filling up. And this is using, the only way we can get this fraction is auscultation, which is listening. We're going to take a look at that in a minute. Or we can only find the systolic using palpation. We will take a look at that next. Equipment, what do I need? I need a BP cuff with the sphygmomanometer system and a stethoscope. I need the methods. I need these methods and considerations. Appropriate cuff size. If it is too small, my blood pressure will be erroneously high. Error high. If it's too big, it will be erroneously low. I can use the auscultation method or the palpation method. نشوف. How to find the brachial artery. This is my arm. This is my forearm. This is my hand. My palm is facing upward. This is my elbow. I find my radial pulse over here, under the thumb. And I draw this is my body over here. And I draw a diagonal line with my finger to the inside of the arm. Between the bicep and the humerus, that's where my brachial artery is. Let's see. That's the brachial artery. That's what I want to find. That's the one I'm going to listen to. My BP cuff is going to be coming over here. It is going to compress the bicep with the tricep, with the humerus, so it can compress the blood vessel and I can take my blood pressure. Let's see the description we have. Find your radial pulse under the thumb. Draw an imaginary line with your fingers diagonal to the inner elbow. The brachial artery is between the bicep and the humerus. Steps to take the blood pressure. First, the common thing among the palpation and the auscultation is to actually uh, get the deflated cuff, make sure that there's no air in the envelope in the rubber bladder, wrap it around the bicep and above the elbow. This is very important. Not on the elbow, above the elbow. Keep looking at the sphygmomanometer. This is where your eyes stay. If I want to listen, I'm going to place the diaphragm head of the stethoscope. The stethoscope has two heads. That's the diaphragm head, and it's meant to listen to the higher frequencies, the heartbeat, my breathing, so on. This is the bell head. This is for lower frequencies. The stomach, for example, I can listen to the stomach using the bell head. I can listen for distinct sounds inside the heart. So I'm going to place the diaphragm head, which is the larger head of the stethoscope, over the area where I find the brachial pulse. I'm going to inflate the cuff to about 220 millimeters of mercury. It can be 220, 200 even. And use the screw valve to slowly release the air. But first I need to make sure it's closed before inflating, or else the air will just keep on running out of it. And I'm gonna start watching the meter. When I first hear the throb starting, that corresponds to the systolic blood pressure. The last throb I hear is the diastolic blood pressure. If I want to use the palpation, I can inflate the cuff, same thing. I will do the same thing, and I will put my fingers over the radial pulse. It should be absent. As I deflate, when I first feel the radial pulse, when I first feel it come back, that corresponds to the systolic blood pressure, and that's it. Because I cannot tell the other radial pulses which one is going to be the diastolic. That's the diagram. That's the brachial artery. That's the BP cuff. This is the sphygmomanometer. You can hear the pulse at first, and then the last pulse I hear when I cannot hear it anymore. That's the diastolic. When I first hear the pulse, that's the systolic. So there is that difference of pressure. That's my blood pressure. And these are the ranges as per the heart organization. And look through those. How to measure the glucose in the blood. The method, it is a minimally invasive blood sample, a small drop. Tip of the finger or the earlobe for kids, for example. I can use their ears for the infants. The equipment I'm going to need is the glucometer set. It comes with the glucometer, it's going to have alcohol pads. The lancet is the pinprick, and the test strips that are going to take my blood sample. When I need a plaster and gloves. Don't forget the BSI. How to measure it? So this is what we have. This is the glucometer. These are the lancets. This is a safety. This is a safety lancet, which means I basically push this button, I remove the cap, and it will do the job for me, and then I just throw it away. These ones, I have to remove the cap, and I have to insert it into the pen and set the settings to be able to prick. These are the test strips. And of course, I'm going to need a finger. Steps. Gloves on. We're dealing with blood. Prepare and load the pen with the lancet. Prepare a test strip and the glucometer. Most glucometers, when we put the lancet in it, the test strip in it, it will automatically turn on. So that's the pen, and those are the lancet. This cap comes off, and I put it first with the cover. Once it's in with the cover, I remove the cover. And then I put this cap back on it, and there's a dial over here how deep it's going to go, how deep the pinprick will go. I'm gonna get an alcohol pad and tear at north. That's my alcohol pad. This is where I want to tear it from. I'm gonna tear from here and go down, tear from the north. I'm gonna swap the finger from the in out. That's my finger. This is where I want to test, for example. I'm gonna swipe from here and I'm gonna go out. I'm not gonna go like this out. I want to take all the bacteria outside. I'm going to cock or trigger the spring and set the depth number on the dial. These are the depth numbers. To trigger or to cock the pen, it's either a click on the back or some other mechanism, depending on the pen and the instruction manual. To trigger the spring, then I'm going to hold the pen firmly on the tip of the finger and press and release the button. I'm going to swab with alcohol. Again, the blood comes out. I swab with alcohol, then I put the test strip into the glucometer and approach the blood from below. This is my finger. And this is my blood. Then what I do is I get the test strip and I'm going to take it from here. This connects to the glucometer. And then I get my reading, clean and swab and with a cotton ball and put a plaster. SpO2 or the pulse oximeter on the index finger. This is the oxygen saturation. That's the oxygen saturation. And this is the heart rate. Respirations, the normal boundaries are between 12 to 24 breaths per minute. Temperature 37.23, it's okay. Oxygen saturation, the important thing, it should be above 95. We will talk in the medical part more about what to do and what to consider when it's going equal to 95 or below it. Blood sugar level, these are the ranges. It's important to have them. I want to thank you all for taking interest in these workshops. And it's a huge relief that we are able to upload them in YouTube so that you can watch them at your own convenience. It's easier for me and it's easier for everyone else instead of having to limit their schedules because many people want to do their own things. So we will keep you updated on when the next workshop will be, that we will start with the medical part. If you have any question, go to our Instagram page. Perhaps you can leave a comment below and we will answer you. Visit the Instagram page, Rafiq Hariri University First Aid Club, RHUFAC. Subscribe to us because all of the webinars and the workshops that we will cover will go on YouTube for future reference.